thank you for joining us this evening. We just had to wait for a few people to make sure everybody was registered. Welcome to the How to Manage Intercurrent Illness in Type 1 Diabetes webinar. Just a few very quick housekeeping points. There'll be 10 minutes questions at the end. We may look to see if we can go a bit over that, but we're not going to spend all evening taking questions, don't worry. There is a question and answer function that you can submit your questions through, and we will also be sending an evaluation form through after the event. If you're able to fill that out, that'll help us to improve the next webinar we do. I'll hand you over to our chair for the evening, Debbie Hicks.
Good evening, everybody. I'm delighted to be able to talk to you this evening and introduce our speaker, who is June James, who is a very well-known diabetes consultant nurse. She actually works at the University of Leicester as an associate professor, but also her speciality within diabetes specialist nursing is the care of people with renal problems. And it gives me great pleasure to ask her to take over now. But as our host said, please do write your questions down for June, because we can actually theme them and make sure that all the questions that you have tonight are actually answered by June. So June, please take it away.
Thank you, Debbie, and thank you for that very nice introduction. So today we're going to talk about how to manage intercurrent illness in type 1 diabetes. So we're just talking about type 1 diabetes. So this next slide shows my disclosures and tells you where I've received sponsorship and honoraria. But it also tells you that the sponsoring company has provided sponsorship to Trend Diabetes, but they've actually had no input into the webinar content. So let's look at our learning objectives. So as we've already said, we're going to look at how we manage intercurrent illness safely. I'm going to use a case study, which I think might be useful just to cover some points for discussion. The key learning points are how we prioritise the individual with type 1 diabetes and their care during illness, how we manage blood glucose and ketones during illness, whilst also taking into account the appropriate nutrition, hydration and monitoring that's needed, how to manage insulin dose adjustment, and hopefully how we can reduce hospital admission for diabetic ketoacidosis. So if we're going to talk about admissions for diabetic ketoacidosis and what we're trying to prevent, I thought it would be useful just to bring up the National Diabetes Inpatient Audit data, and this was from 2017. And what you'll see is at that time, a huge amount of people were actually in hospital on that day with diabetes, but 1 in 6, that is. The median age was 75, but only 8% were admitted specifically for management of their diabetes. The rest were admitted for other things. So that would be things like to have their gallbladder removed or to have the hip replacement. So only 8% actually were admitted directly because of their diabetes. So I'm going to show you a slide which tells you what they were admitted for now. And this nice summary gives us 5-year data, and I'll just talk it through. So if you can see the first column, which is foot disease, can you see how that we haven't reduced admissions for foot disease up until 2015, which was the last time this was collected in this sort of table form. Hypoglycemia, you can see. But written in red is hypoglycemia, and I'm always really interested as to how people are admitted purely for hypoglycemia if they haven't got hyperosmolar hypoglycemic state and they're not in DKA. So, and there's our diabetic ketoacidosis figures, and they're not good, are they? So we've actually had increases year on in people presenting with diabetic ketoacidosis. So let's talk a little bit more about that. So first of all, it's life-threatening, and some of you will have seen in the press recently another death to diabetic ketoacidosis recently of a young woman. So it is life-threatening. Diabetic ketoacidosis occurs mainly in people with type 1, and we can't say now that it never occurs in type 2 because we're seeing that more and more. It usually is due to an underlying infection, can be post-surgery, and quite often it's when people don't adjust their insulin appropriately when they're unwell, which is what we're going to talk about. New onset diabetes, and often that's where the deaths come in. So people haven't recognised the signs and symptoms of new onset diabetes, so they don't go for treatment, and they die before they're diagnosed. And the cost of an admission for DKA, which is how I'm going to refer it now, is over £2,000 an adult. So I'm not going to talk in any depth on the pathophysiology of diabetic ketoacidosis, but just to say, as in this top box, you can see it occurs because of a significant insulin deficiency and an increase in stress hormones. We then have a decreased glucose uptake by the muscle and fat, and mobilization of free fatty acids from fat cells. And it's this mobilization of free fatty acids that actually produces ketones as a byproduct. We find the liver produces more glucose, and this results in significant hyperglycemia and ketoacidosis. And we're going to look now at the signs and symptoms of DKA. And the most important thing to remember is that these symptoms come on very rapidly, usually over 24 hours. And there's a whole list of these type of symptoms. So thirst is very common. And so if you ask a person that you suspect might have diabetic ketoacidosis or new onset type 1 diabetes, if you ask them whether they're thirsty, they'll say, yes, I'm drinking about every half an hour. They're extremely thirsty, and they're thirsty overnight, so they're getting up several times to drink. And of course, they've got polyuria and nocturia. They often have rapid weight loss over a few days. Sometimes that's difficult to see. And I did have one case where a teenage boy had had new onset diabetes for some time. And of course, it was a time when people wore lots of layers, so a t-shirt and a shirt over the top, those sort of things, and his mum hadn't noticed. So rapid weight loss is a real feature because people are passing their glucose out in their urine. Abdominal pain and cramps, and I've put facial redness in, and that's something that I've seen quite often actually. So a really very, very red faces. As these symptoms increase and as they develop over time, a short time, then you might get nausea and vomiting. You'll get breathlessness, and in particular, the breathing will be something described by Kussmaul, which is a slow, heavy breathing. People feel breathless, and that would lead to confusion, coma, and death. So let's look at the clinical signs that we would see. So I put here that the capillary blood glucose might be 30 millimoles or litre or high on a blood glucose meter, but you mustn't be fooled by that, because when people become severely dehydrated, you might not see a high glucose reading. And if you look at any of the meters in the little fact sheet at the end, it will say, be careful in severe dehydration because the meter might not read correctly. It might read low. You will always see ketones, either in the blood or the urine, significant dehydration, and the pH will be less than 7.3, the bicarbonate less than 15. And then you have a severe electrolyte imbalance with loss of sodium, potassium, phosphate and water. So it's once you suspect this condition, you should be able to recognise it by these signs and symptoms. So let's look at Emma. So she's 33 years old and she's had type 1 diabetes for some time, and she's on a basal bolus insulin regimen, and here's the names of the insulin. She's got flu-like symptoms. She just really doesn't feel very well. So she either telephones the practice or maybe a diabetes specialist nurse helpline just to ask for some advice. So we're really looking at trying to help her so that we can give her effective sick day advice so that she doesn't progress to diabetic ketoacidosis. So this is the sort of information that we need. So we already know what type of insulin she's taking, but what doses is she taking? Is she actually taking it? Has she missed a few doses? What are the other signs or symptoms? Because we're looking at some of those others that we've just discussed. Can she take fluids? That is a really important question. If she can take fluids, you may be able to manage this at home. Can she eat? Does she have ketones, and if so, how many? Is she breathless, as we discussed before? So Kussmaul's breathing is associated with acidosis. And is she pregnant? It's really important to know if she thinks she's pregnant or if she is pregnant, because if she is, you can bypass everything else because she's going in as an acute emergency to hospital, because ketones are toxic to the fetus and can kill a fetus in less than 24 hours. So if she's pregnant, you need to send her straight in. So let's look what she tells us. So her temperature's okay, and I was thinking about this in respect of COVID. She has no pyrexia. She's got positive ketones as shown. Her blood glucose is about 15. And when you ask her, she missed a few doses of her Nova Rapid because she didn't feel like eating, so she didn't think she'd take it. But she also, more importantly, didn't take all of her long-acting insulin, so she only took half of the Levemir. She can take fluids. She's not short of breath. She thinks she's got a head cold. She's not pregnant, and she's got ample stocks of insulin and blood glucose and ketone strips at home. So this is the sort of person that we could probably look after in the home setting if, as a healthcare professional, you've got the confidence to do that. So let's look at the sick day principles for type 1 diabetes. So some of you that will have heard a talk on sick day principles and type 2 will know that focus entirely on blood glucose. But in type 1 diabetes, we're focusing entirely on ketone reduction because it's the ketones that are doing the harm. So we would never omit insulin, and we've almost certainly got to increase it. She would need to be able to maintain a fluid intake, so at least 100 mils per hour, up to 3.5 litres. She needs to be able to drink plenty to correct her dehydration. And we want her to be able to test frequently for blood ketones and for glucose. So, and also she would need to rest. So her body is going through a lot. When they've got a lot of ketones, she needs to rest and then take advice on insulin adjustment. So if she doesn't want to eat, not so worried, as long as she can drink, and she could have replacement foods. And I've taken this from the Trend Diabetes leaflet that you'll hear about at the end. So if you look in our sick days leaflet, you'll see there's 2 algorithms. You probably can't see them well on the screen, so I'm going to switch over to the next screen, which will show them bigger. So if you remember, we were talking about we're managing her diabetes and her insulin dose according to blood ketones. So this algorithm tells you what to do or what to advise if the blood ketones are less than 1.5. So this is a patient leaflet, so it's for a person with diabetes, and it's very clearly written. If the blood glucose is more than 11, ketones are less, this is what you do. And in that scenario, you would test the blood glucose and ketones every 4 to 6 hours, as long as they can drink. If they need to take more insulin and the glucose is above 11, we advise exactly how much to take. So, and I don't know that I've seen any other leaflets very much. There are 1 or 2 that says this. So it will tell you glucose between 11 and 17, you add 2 extra units. If it's higher than that, you add 4. If it's more than 22, you add 6. And if that doesn't resolve things, then you may seek other advice. Now, I just want to talk a minute about the fact that we've said glucose is more than 11, because you will see in other organisation 6-day rules that that number varies. So some would say 12. So the Joint British Diabetes Society says if it's more than 12. The Primary Care Diabetes Society, I think, says more than 13. It's a little bit academic, and we'll be looking again at more evidence to give an accurate reading for this. We go to 11 because we think we'd rather be cautious. I'm not saying other people's are wrong, and I don't think they are, because what we're really concentrating on is the blood ketones. It's the ketones that's the issue. So if we go on to the next algorithm, so this is where the person learns how to manage their insulin dose when the ketones are more than 1.5. And again, we've got that glucose reading, but we're now going to still carry on with fluids, but test every 2 hourly. So lots of fluids, test every 2 hours. And now we've got these 2 algorithms at the bottom. So you either have an extra 10% of your total insulin dose, depending on how many units, or you might have 20% if the ketones are more than 3 millimoles per mole or millimoles per litre. So it all depends on the ketones. Clearly, at any stage in both of these algorithms, if the person is unable to keep fluids down, then they need to be admitted to hospital, or at least for assessment in hospital. So you can only use these algorithms if that person can keep fluids down, is able to test, able to adjust their insulin, and confident to do so. So do people with type 1 diabetes always know how to manage intercurrent illness? Well, no, not everybody does. And it depends, it's a bit of a geographical thing as to how much information people have. It varies from person to person. So somebody with diabetes might only see a healthcare professional for about 3 hours a year. And if you think of the COVID crisis, they're not even doing that at the moment, are they? And we've been going on three to 4 months with that. We know people living with diabetes should have access to structured education, and it's endorsed by the national bodies. And we would hope that every individual with type 1 knows how to manage intercurrent illness, but not all do. So certainly in my area, in Leicester, people with type 1 diabetes in our adolescent clinic, even 2 years ago, were each sent a leaflet on how to manage intercurrent illness, and those leaflets have gone out again because we've had the COVID crisis. So it's really, really important that you can do this. Everybody with type 1 diabetes must have a blood ketone meter, and they must have ketone strips, because they need to know how to self-manage in illness. And every person should have sufficient blood glucose testing strips for use in intercurrent illness. So even people on insulin pumps should have a spare supply of blood glucose testing strips, even if they use a different method of testing their glucose. So, and that's really, really important. So if you're going to manage intercurrent illness yourself as a person living with a condition, you have to have the equipment to help you do that. So here's our leaflet, which is freely downloadable on the Trend website, and the link is there. And then I just put this other algorithm up, which has been kindly developed by Dr. Kath Higgins at Leicester. And so when people come to accident and emergency, or MAU, junior staff would be able to use this this decision tool, and it will help them decide whether the patient has just got hyperglycemia but isn't in diabetic ketoacidosis. So if you look at the JBDS guideline at the front door, you'll be able to copy and paste this leaflet, which is really useful too. So thank you for listening, and I'll be happy to take your questions.
Okay. To me. Hello, so I'm back again, and I've got a few questions from the audience, and I'd like to start off with one from Debbie. I'm not sure where Debbie is, but she's actually talking about the algorithms that we have in the leaflet, and it's actually saying it doesn't specify whether it's rapid acting or long acting insulin. Would you like to answer that one, June?
Yep, that'd be fine. Well, my Emma has rapid acting insulin in the house, and I'm really lucky about, because that was an easy one. Not everybody will have rapid acting insulin. So if it's, say, a person with type 1, there's not many these days, I hope, that are on a mixed insulin, but quite honestly, it doesn't matter. I would still give them the mixed insulin. If there's nothing else in the house, some insulin is better than no insulin. So I would still give them the mixed insulin. When somebody's severely ketotic, they actually don't go hypoglycemic till the ketones start leaving. So you can be fairly reassured they won't go hypo until the ketones are gone, and then you need to reduce everything back.
Okay. Thank you, June. I think the person was perhaps alluding to the fact that, if they are on a basal bolus regimen, would they be increasing both of those insulins?
I would probably stick with the Novorapid, the fast acting.
Yeah, because increasing the basal insulin is unlikely to have any major effect on high glucose levels within a short time. So it really would be the short acting insulin that would be the one to increase, as the algorithm suggests. But somebody else has actually asked about what if the person is confident with correction doses, do they need to stick to the table? Well, I would say, if I can kind of jump in, June, that if somebody is confident with correction doses, whether they're using a pump or whether they're carbohydrate counting, then no, they would stick to what they're confident, as long as they are able to monitor the ketones. Would you agree, June?
Yes, I would agree. I think that's very wise advice. I mean, you really need your rapid insulin to be doing what it says. You need a rapid acting insulin to really get rid of your ketones. But people on an insulin pump always know what to do, in my experience. They've been very well taught, and they know how to manage their diabetes well and how to adjust the doses, and we always feel very confident with them.
Okay. So we have another question which basically says, would we treat children with type 1 diabetes and DKA any differently to adults?
Yeah, so I'd dial 999. They'd be going to hospital immediately, even if they could drink. So if it's a child or a pregnant lady, they need urgent admission to hospital. In pregnancy, as a diabetes nurse, I would ring the A&E, and then I would ask to speak to the on-call diabetologist as well, and the obstetrician. So it really is extremely urgent, and the same with the child. So if a child has DK, they go straight to hospital, and I would always ring the paediatrician on call as well. This is very, very serious. They need to be met at the front door to have treatment.
Thank you, June. There is another question here about primary care, and what about measuring ketones in primary care, and is there a level at which you would send somebody to A&E directly?
I think in primary care, we would say you're going to go A&E directly. If the individual, the healthcare professional, is not very confident, certainly with a level of 3, I would say you'd be going to A&E. Diabetes specialist nurses are often very, not all of them, but some are confident in managing sick day advice, and it all depends on your scope of practice, really. So I would say 3. If you're not confident, just send them anyway, because it doesn't do any harm to get an assessment there.
Okay, so one of the things that we do believe is very important, which is why we talk about measuring ketones in primary care in the type 2 leaflet, is that during this pandemic we have seen quite a few people actually admitted to hospital with ketoacidosis that have type 2 diabetes, and they're not necessarily on an SGLT2 inhibitor. So we do believe that it's important in primary care to at least be able to check for ketones when somebody is acutely unwell. We're not saying in people that are well, but certainly if somebody is unwell, we would consider checking for either urinary ketones if you don't have a dual meter, but certainly some means of testing, and that may well prevent a hospital admission. But we just have got another question, and I wonder if we could just ask about regarding your case study, June. Somebody has asked specifically for Emma, would you have asked her to have the second half of her 11 dose at that time?
Yes, I would. Yep, I would ask her to take that dose, the second half there and then. I'd be increasing the Nova Rapid, because if she's missed the whole 24 hours with only half a dose, you're going to have to play catch up, aren't you, to get the basal right. So yes, certainly I would do that.
Okay, we have another question. We have another question for you, June. What somebody has asked is, how do you rate urine ketone strips against blood ketone strips?
I'm a bit old school, so I'm sort of reasonably okay with urine strips, because in the olden days, when Debbie and I started off, that's all you had. But there's always a problem with urine ketone sticks, because really you're testing a sample that's perhaps been in the bladder for quite a long time. So it's not particularly as accurate as you would want. So it could tell you if it's positive, but it's more difficult to check, to say whether it's truly accurate at the reading that you're getting. Blood ketone sticks are the gold standard. And where possible, whether if you're a healthcare professional testing somebody with type 1 or type 2, you should really use the blood ketones testing. Having said that, on our leaflet, we decided to put the urine results on as well. So as a community diabetes nurse, when I worked in Peterborough, it was bread and butter to us. We would adjust insulin according to the urinary ketones, because that's all we could. But in this day and age, when we've got state-of-the-art meters, and you're not going to use them every day, it's well worth practices having their own system so they can test properly.
Yes, thank you for that. I mean, I work with a group of practices, excuse me, 15 practices, and all of our practices have a dual ketone and glucose meter to make sure we've got an accurate reading to assess somebody that's unwell. However, Jim, we do have a couple of questions, and I appreciate that we've had lots of questions, and I hope that we've answered a lot of them, but we've got time just for a couple more. And somebody has asked about should everyone with type 1 diabetes be prescribed ketone sticks and have them on repeat prescription and know how to use them? What do you think?
I think I said about in my talk, everybody with type 1 diabetes must have ketones. They should have them at hand, because if they're ill in the middle of the night, you know, you won't know. They won't be able to treat themselves. They won't know their ketone readings, so they must have it. Now, whether it's on repeat, that's a much more difficult one, because, you know, they're only going to use them every so often when they're unwell. So I probably would say not on repeat, but if they request them, because, you know, they've only got a small supply, it should always be sanctioned by the practice. You know, they shouldn't be, well, you had some a month ago, so you can't have any more. They need to have their ketone strips. What would you say, Debbie? Because you're in general practice, would you say on repeat?
Yeah, I mean, what we did quite a while ago is for type 1 diabetes, we made sure that they were accessible as and when they need it. So it wasn't on repeat, but each of the practices were aware that, you know, people don't necessarily keep up-to-date strips available, or they might use the last one. But fortunately, we don't tend to waste the blood ketone strips anymore, because they're all individually foil wrapped, and now they are a lot less expensive than they used to be. So I think that we've moved forward a little bit with both cost and also kind of lifespans. But what I wanted to ask a question here from somebody that has asked, how do you feel about people on a carb-free or very low-carb diet? Are they at greater risk of DKA if they become unwell?
I don't think they're at greater risk. They tend to test for ketones anyway, because they need a certain level of ketones to know that their low-carb diet is working. No, I don't think they're at greater risk. I just think they need educating so they know when the level gets sufficiently high enough. Because remember, people would be feeling unwell. So it's not the reading per se, as much as they don't feel very well, and that's when they test. So if you're on a low carb diet and you've got a small amount of ketones, I expect that's what you'd expect to see. But if you suddenly become unwell, then you need to monitor the rate and the blood glucose.
Okay. We've got another question. We have the last question, and I really apologise to everyone that has put the questions to us. And this person has actually asked, how do you manage ketosis in the end of life care? Now, June should be able to answer this very easily because she actually co-wrote the end of life care document. So what do you think the advice should be for this, June?
Well, what a good question, and thank you for asking it. So in end of life care in people with type 1 diabetes, you must never entirely stop the insulin. They must always have at least a long acting insulin, so one of the very long ones. So when I've nursed people in end of life care, then we've usually given a very small dose, maybe 6 units of insulin in the last day or so. If we stop the insulin entirely in somebody with type 1 diabetes, they will go into ketoacidosis, and believe me, that's a terrible way to die, with the severe thirst, dehydration, electrolyte imbalance. So if you look on the Diabetes UK end of life guidance, it will clearly tell you the insulins that are most useful to use. So things like Tresiba or Glargine, and you would give a small dose, but you never stop it. You never stop it.
Okay, so we are at 45 minutes now since we started, and I'd like to take the opportunity to thank June for her excellent presentation, and also to thank Orange Juice Communications for doing all the logistics, and very much to Novo Nordisk for giving us this opportunity to speak with you and be able to share this information. And for any of you who are not members of Trend Diabetes, then please do look us up on Google. It's free to join, and you can access all the resources that we've got available. But again, thank you very much for joining us, and good evening, everybody.
Good evening.